Good morning, everyone. We are about to start our session. So I'd like to take this opportunity to welcome the moderator. You're welcome. The floor is yours.
Hello. Good morning. Welcome, and thank you so much for joining this forum. I understand there are many other sessions going on in other rooms at the same time, so therefore your presence here today means a lot to us, and we don't take anything for granted. So thank you again for joining us today. In this forum, we have colleagues who are already online, and I want to apologize for keeping you waiting. After the first sessions in the morning, we lost some time, and people had to go and get some breakfast. So I apologize that we had to wait for a long time. We will start with some speakers here, but there will be opportunities for colleagues online to ask questions. If you want to ask a question from online, you just need to unmute yourself. Because we have muted all of you from here, but you can unmute yourself if you want to speak, and we will give you that opportunity. Today we are going to have a discussion about comprehensive post-abortion care. There are different documents where comprehensive post-abortion care is presented, and we always see different data which is being presented to represent the burden of unsafe abortion in Tanzania and the burden it puts on the former national health system. There are documents where we see 3%, as a contribution to maternal death. There are documents where we have seen that unsafe abortion is contributing 10%. There are other documents where we have seen that it contributes between 16 to 25%. I think we all know and agree that, often, given the sensitivity of the subject matter, abortion-related data is usually unreported. Therefore, the percentages we are seeing in different documents may not be presenting the true picture on the ground. Post-abortion care is recognized as a life-saving intervention and is one of the signal functions of basic and comprehensive emergency obstetric and neonatal care. Healthcare providers in Tanzania are therefore required to provide CPAC services to all women with dignity, without any form of restrictions, stigma, regardless of the etiology of those abortions. However, unfortunately, comprehensive post-abortion care services are not very much prioritized, and actually many times they're not even tracked in major BMOC and CMOC interventions. And this leaves a critical gap in terms of service provision. Over the past few years, the government of Tanzania, in collaboration with different maternal health stakeholders, has made significant strides in institutionalizing CPAC services to increase access in order to reduce avoidable maternal death. Today, in this forum, we will take a deep dive, looking at the past, looking at the present, and looking at the future with regards to provision of CPAC services. My name is Joseph Komuyangira. I'm the country director for PATHFINDER in Tanzania, and I will be your moderator today. And I would therefore like to invite our keynote speaker, Professor Andrea Pembe, to present his analysis of the situation and set the scene for further discussions. I trust this forum will be engaging and will be interesting. Now I call upon Professor Pembe to come and take the podium to give us his keynote address. Professor Pembe is a Vice Chancellor of Muhimbili University of Health and Allied Sciences. He has more than 30 years in clinical practice and over 20 years in academia, teaching and guiding undergraduate, postgraduate, and PhD students, and also doing research. His areas of interest include research on reproductive health, research design and policy development. He is conducting research with several local and international collaborators and has more than 80 publications in peer-reviewed journals. He sits in different boards, in-country and out of the country, and in advisory committees, including the Inter-University Council of East Africa. Professor Pembe holds a degree in medicine from the University of Dar es Salaam, a Master's of Medicine in Obstetrics and Gynecology from the University of Dar es Salaam, and a PhD in maternal and newborn health from Uppsala University. Please let us welcome Professor Pembe on the podium. Karibu sana, Professor.
Good morning. I was born before the technology. Therefore, I'm BBC. When I finished university, there were only 3 computers. And the one room, when you enter there, you have to take out your coat because you bring viruses. But anyhow, thank you very much, moderator, for a generous introduction and your kind words. Most of us always were discussing the issue which is related to abortion care. And all of us, we have heard of abortion. Just for a snapshot, when I finished my first degree, I went to Buganda Medical Center. And immediately when I finished my internship at Bugando, I joined Sekoture Regional Hospital. It was an urban health center, and I had to open as the regional hospital for Mwanza region. On my first week at the hospital, one lady, who I'm calling a woman in red, came to my office and they asked for termination of pregnancy. I responded simply from what I was taught in medical school, that abortion care is unlawful in Tanzania. Ndio, mkutano unaendelea, sijui kama unatusikia. Hello? Do you hear me? We have started already. Yes. Do you hear us? Thank you so much. Can you mute your mics? Thank you. Now, from what I was taught in medical school, I responded very, very simply that termination of pregnancy is unlawful, and I do not provide any assistance. Because when we are taught in the 3rd year the medical legal aspect related to gynecology, we are taught only some sections which are related to the Penal Code, the Black Book. And this is in Chapter 14 of the Penal Code, Section 150 to 152, which penalizes abortion. 1 week later, I received the same lady. She was in shock, bleeding, and in sepsis. Therefore, I asked myself, did I do the right thing to this lady? From that time, I started thinking more of abortion and reviewed the laws in Tanzania, where I discovered that abortion law in Tanzania is not so restrictive. First of all, there are some sections, 214, 219, of which abortion can be done to preserve the well-being of the woman. Further later on, the Maputo Protocol came in, where the Tanzanian government ratified the Maputo Protocol, although it was not domesticated, whereby abortion can be done when you are having rape, incest, and the others. Therefore, the issue of abortion and the laws within the country, I'm sure that is a little bit ambiguous, and it has to be much more clear than it is today. We have to rethink again, are we denying these women correct information? And when I'm talking about the correct information, maybe something could have been done at that time when she approached me the first time. I could have provided clearly different informations related to abortion, different methods used for termination and abortion, and the complications which are associated with that termination, and then leave the woman to choose. I could have saved her life. Therefore, that is the first thing which we as healthcare providers, we may do. But if that fails and the woman has unsafe abortion, we have to do something. And this is abortion care. And when we are talking about abortion care, there are different definitions which are here. Most of them, they are thinking only of the treatment of abortion complication. And most of the time is incomplete abortion. But we have post-abortion care, which has 3 components, where there is a treatment, but as well there is provision of counseling on family planning, and at the same time ensuring that the woman has choose the right method when she's getting out of the facility. And where appropriate, that woman should be referred to another facility. There's a terminology of which the moderator spoke about, and this is a comprehensive post-abortion care, whereby there are 2 more components than in post-abortion care. You are linking your services within the facilities and the community, but as well you advocate for the law change. And then there is another aspect, and this is the CAC. Now, comprehensive abortion care is when also you are advocating for the quality of abortion services. Therefore, after the abortion, there is something else of which we should do. I end up with after because of my own mistakes, which I've done before. My colleagues, when looking at the total abortion in the world, about 42 million women, they terminate pregnancies. And among the developing countries and middle-income countries, low and middle-income countries, is the major part of all these abortions. Only 6.2 million are happening in developing countries. The worst scenario which we have in the world, in these low and middle-income countries, majority of them, they're unsafe compared to to the developed world where abortion is safe. In Tanzania, Keo et al. In 2013, they collected data to estimate the rates of abortion in Tanzania. According to their publication of 2015 in PLOS One, we had 1 million unintended pregnancies in Tanzania. And the estimation showed that about 405,000 abortions were unsafe. Our rate of abortions is not very, very different from the rest of the East Africa region. It's about 36 abortions per 1,000 women who are in reproductive age, and then when you're calculating the rate, it's about 21 abortions for every 100 live births. These numbers are very high. When looking to the pregnancies which are occurring in Tanzania, and looking to the percentage of pregnancies that are unintended, you will find that intended pregnancies, it's only 52%, but majority of unintended pregnancies are the ones of which they are terminated. We have to know that some of the intended pregnancies as well, they are miscarried. That is spontaneous abortion, and some of them, they develop complications and they need treatment of comprehensive post-abortion care, depending on the area. When looking to this figure, you find the percentage of pregnancies that are intended. And then you could see what proportion is ending up in abortion. It shows that at the national level, we have about 15% of the intended pregnancies of which they are unsafe abortion. Now, the Lake Zone is far beyond the national average, and this is not only to the intended pregnancies, but as well when you are looking to the number of abortions per 1,000 women of reproductive age. Nationwise, we are saying that around 36 abortions per 1,000 women who are in reproductive age. But the Lake Zone, Southern Highlands, and the Western Zone, they have the higher levels compared to the national level. And the lowest it is in Zanzibar. And if you see clearly in the previous picture, is that even the proportion of those intended pregnancies which are end up in abortion in Zanzibar are much more lower. This is a situation which had been in this country for a very long time. I'm sure what this report shows is just a tip of the iceberg. There are much more which we have not been shown. Therefore, in 2018, looking to the situation which we had to conduct the National Technical Consultation Meeting, at least to reflect on the status of CPAC services in our country, and set the milestones for improvements. During this consultative meeting, there are a number of key issues of which we identified, one of them being the role of electronics in provision of comprehensive post-abortion care. I know there's a lot of discussion about it. Some people are thinking that if you provide misoprostol People may use it for termination of pregnancy. But sometimes as a clinician, and which I've experienced the bad outcome, I ask myself, can we go leave the woman terminate pregnancy with a method which can end up in a severe complication which can lead to maternal death, or the woman uses misoprostol, which is much more safer. But at the same time, when I'm looking to another level of our services provision for comprehensive abortion care in the remote facilities, a dispensary with a nurse, someone having an incomplete abortion, spontaneous abortion, which became an incomplete, and she needs care, and one of which is a referral. Is it better to refer these women with a dose of misoprostol, or leave her continue to breed until she reaches the facilities? I'm sure with the ethics which I had and the experience, I will say, please give misoprostol to the facilities so that we can prevent more death. Then the issue of the young people accessing the services. And here, mostly, are our adolescents with all the stigma which prevails around sexuality, pregnancies, and the use of contraception. How can we increase access of the young people to the use of the reproductive health services, but at the same time ensuring that we prevent these young people from becoming pregnant? Then look into the CPAC guideline which we had. It had, for the pregnancies which are above 12 weeks, there was a little bit of controversies on its management. Therefore, there's something we could review the guideline and improve what we have in order to have a clear guidelines on management of post-abortion care after the first trimester. Now, the quality of the services, therefore, themselves, we have as well to look into. Are they aligning with the standard of care? And here, we concentrated most with the use of sharp curettage, which has been used over the years. Then we changed to MVA before the medical management of incomplete abortion come into place. Do we have quality pain management for women who are receiving comprehensive post-abortion care in our facilities? And what about infection prevention, which is so crucial, because sometimes instead of saving the woman, you may make the life much more difficult for these women. The fifth one had been, like the first one, the use of urotonics in provision of CPAC, because it was ambiguous within our guidelines in the Ministry of Health. And the access I've talked about, I'm sure here there is a little bit of the repetition. Therefore, after thinking all of these issues which we had, we have to think what are key milestones on improving the quality of the services in order to enhance availability of the national CPAC data, because this will inform programming, but as well as the policy decisions at the national level. Therefore, the intended delivery, which we had, first to develop a dedicated CPAC-specific health management information system tools, and secondly, to integrate CPAC data in the DHIS 2. Another key milestone had been to develop the HMS tools to enhance availability and inform programming These slides of mine, how are they working? Yeah. Okay. We have milestone 1 to improve the quality of CPAC services, and the intended deliverables had been to develop guidelines on the use of electronics, review of the 2015 CPAC guideline, and eliminate unnecessary use of sharp curettage. And then we had key milestone 2, of which I've already talked about. And then we had key milestone 3, which is the increase of access of the quality of the CPAC services. And here the intended deliverables has been the rollout of misoprostol for the treatment of incomplete abortion, especially to the lower facilities for the reasons which I have mentioned. Then the integration of CPAC in the emergency obstetric and neonatal care services. This is very, very crucial because it has been forgotten a lot. We are teaching, we are training the rest, but when it comes to CPAC, it was left behind. We had a value clarification and attitude transformation on CPAC. This is quite crucial because of the stigma which is associated with the sexuality, is associated with the pregnancies, which is as well associated with the termination of pregnancy. It is not only to the community, but even among the service providers. And lastly, is tax sharing for the CPAC services. Now, where are we today? When we are looking at the guidelines, we developed the guidelines in which the ultrasonic guideline so that misoprostol was well included. The aim of this guideline is not only for the CPAC, but ensuring that the quality of the services of the use of the ultrasonic is known within Tanzania. But also in 2020, we developed the CPAC guideline whereby misoprostol was as well included, use of sharp curettage clearly clarified, but at the same time, CPAC for the pregnancies more than 12 weeks was as well put much more clearer, and inclusion of pain management and infection prevention. For the milestone 2, the CPAC specific health management information system was approved in 2019 and rolled out in 26 regions in Tanzania, and the data reported in the DHS 2. And this was around 1,130 facilities. As you know that this is only around, 15% of the facilities in Tanzania. The current performance for milestone 2, around 3,000 monthly average CPAC uptake national is reported within DHS 2 from the 1,130 facilities. 70% they are using MVA. This is very good from the main use of the sharp curettage. The sharp curettage remains 16%, although some of us you think is still very high. When looking at the use of the medication for the treatment of incomplete abortion, it's around 14%. There is 63% average of the clients of which they are using family planning after abortion. And we know that we intend to prevent further pregnancies. And then 700 monthly average CPAC uptake reported in DS2 in Dar es Salaam alone among the 19 public health facilities. For the milestone 3, the treatment using misoprostol was allowed 15% of CPAC services. There is clarification of the abortion law is provided within the guideline because we wanted especially the healthcare providers to be very, very clear what our national law states. And I'm sure that it's among the best across the East Africa. Much more integration of the CPAC within the ELMOC is ongoing, and we think that the progress is good. Now, where should we prioritize for the coming 5 years? I give you to discuss, but to me, first, create awareness across the communities and ensuring that the community is destigmatized on issues related to sexuality, pregnancies, abortion. Some abortion are spontaneous and much more. But more than that, we have to go to the system aspect. How does our system perform, ensuring that we have the quality services in Tanzania, from the lowest facilities to the highest facilities? These are two of my statements, of which I'm sure much more clarification is needed. Thank you so much.
Thank you so much, Professor Pembe. Professor Pembe, please take a seat on the stage. You are one of our panelists. Please take a seat on the stage. And now we have 4 more excellent panelists who are here with us today. I'm going to call them one by one, and we invite them to come on the stage, and they will lead the discussions. And we also have time for colleagues online and in here to ask more questions. The first panelist is Ms. Jean Liatu. Dr. Jean Liatu is a clinical quality advisor for sexual reproductive health and family planning at PATHFINDER International, Tanzania. She has over 15 years of experience in clinical practice and public health management. She holds a degree in midwifery from the University of Dar es Salaam and a master's in public health for international development from the Netherlands. Please join me to invite Jean to the stage. Our second panelist is Sister Rehema Nyachuma. Sister Rehema Nyachuma is a registered nurse and a hospital matron at Vijibweni Hospital in Kigamboni, Dar es Salaam. She has over 12 years of experience in clinical practice and nursing care, and close to 8 years in hospital management and leadership. She is a service provider and a national trainer for BMOC, IPC, and she's a clinical services mentor for family planning and postnatal care. Please join me to invite Sister Rehema. Our next panelist is Dr. Yahaya Kapona. Dr. Kapona is the president-elect of the Association of Gynecologists and Obstetricians of Tanzania, AGOTA, and he is a managing director of Tikaya Health Center. Having served as a senior consultant at Muhimbili National Hospital for over 24 years, Dr. Kapona has over 35 years of experience in clinical practice, research, and training in obstetrics and gynecology. He has contributed to development of various guidelines and training materials with the Ministry of Health, including the comprehensive post-abortal care, PMTCT, life-saving skills packages, which are now known as comprehensive and basic emergency obstetric care. He holds a degree in clinical medicine from the University of Dar es Salaam, a master's of medicine in Obs and Gyn from the University of Dar es Salaam. He received further training in reproductive health and demography from Thailand, and a training in andrology from Greece. please join me to invite Dr. Kapona. And our last but not least panelist is Dr. Ahmad Makuani, our own Dr. Makuani. Dr. Makwani is a director of preventive service is director of reproductive and child health department of the Ministry of Health. He's a senior consultant in the Ops and Gyn, and he has over 25 years of experience in clinical practice, public health, and research. His areas of interest include reproductive health, maternal, human, and child health policies, service delivery, and surveillance systems. He has championed initiatives to reduce maternal mortality and the development of different RMNCH guidelines, policies, and training materials in Tanzania and beyond. Dr. Makwani holds a degree in clinical medicine from the University of Dar es Salaam, a master's in Ops and Gyn from MUHAS. He has received several additional trainings in this area, nationally and internationally. Dr. Makwani is also a visiting lecturer to the University of Dr. Makwani in the UK. He visits the University of Liverpool School of Public Health and Tropical Medicine in the UK. So when you don't see him here, you might be somewhere teaching. So these are the 4 panelists. And let me start by thanking you, Professor Pembe, for giving us a very enlightening presentation, shedding light on different issues which we didn't know, and which we have been knowing, but we are not, kind of having current, up-to-date information. I would like to start with you, Dr. Makwani, as a senior government official. We would like to know your views. Many people in Tanzania relate CPAC with abortion. So every time you say CPAC, people think about abortion. And undeniably, there is huge confusion among the general public and service providers on the legal framework of post-abortal care. Would you please clarify the government policy and legal framework for post-abortal care? And what is the government planning to do to raise public awareness about this legal framework? You have 5 minutes. Karibu.
You, Dr. Joseph, Director of PATHFINDER Tanzania, for giving me this chance to explain issues of policies with regard to abortion in Tanzania. First of all, I should thank you also, Professor Pembe, for making my life easier, because he has narrated most of the issues surrounding the post-abortion care in Tanzania. First of all, I started dealing with the issues of abortion in 2012 when I came back from Liverpool School of Tropical Medicine, and it was my first policy assignment to look at the guideline which was being used in Tanzania in guiding the post-abortion care in the country. And at that time, I remember when you talk of abortion, it's like, hey, talk it very slowly. Nobody wanted actually to speak it very, very loudly. And I should take this opportunity to thank the support I received from the Chief Medical Officer of the time, Dr. Donan Bando, and then the Deputy Minister of the time, Honorable Dr. Saif. They encouraged me a lot to dwell this area. Therefore, they asked me, go and make a guideline. Don't use copy and paste approach. So I convened the experts, including Professor Pembe by then, and we met in Bagamoyo. There were a lot of issues, but I was also able to convene the minister legal expert, the head of the legal unit, Madam Patricia Maganga, And I remember Patricia was writing that piece of legal framework with Professor Pembe. I said, you two, you have just to deal on legal aspects. That's where I learned that most of us, medical professionals and the general public, we don't know exactly what the legal framework of abortion in Tanzania entails. It is clear that when you go through it, procuring abortion in Tanzania is strictly prohibited by law. But it gives you an exception where the life of the mother is in jeopardy. That's where it gives you the... And I remember that is an area where Patricia was speaking very loudly, said, don't put statements that is going to cause a barrier of services to women. And I remember by then most of us who came into the room with that thinking of, in order to save a life of a woman, in case abortion is to be procured, you need to convene at least 3 experts. You remember Professor Pembe? And she said, the law doesn't say that. And that is the obstruction of service. So we ended the first phase with a statement which was saying that medical personnel or a care provider who is qualified is the one who can make decision. So these are some of the areas whereby we need to work on. And over time, from that first, I would say the second version of guideline to now we have a third version of guideline, we have tried as much as possible through trainings of healthcare providers and so forth to try to desensitize in the provision of post-abortion care services. We have tried as much as possible the guideline to try to ensure that people are not judgmental. In most cases, when the victims were coming to the health facilities, the first thing providers they do is where did you procure the abortion and so forth. So we tried as much as possible. We need to at least reduce these judgments among the clients, because that is an obstruction of services. When it comes to general public, I think we have a role as experts now to try as much as possible to bring these difficult issues into media, to discuss it in the wider audience along the media. Because most of the time, even today within this discussion here, most of us are experts, but we have not involved the general public. We have not involved the religious people, for example. We need to bring them on board because some of the issues, they need to be discussed with them so that they can take care of it. It is pity to learn that somebody dies in a boat because did not receive a service in point A of post-abortion care. Thank you.
Thank you. Thank you so much, Dr. Makwani, for your response. Now I will turn on to Dr. Kapona. Dr. Kapona, as you know, current WHO guidelines discourage the use of sharp curettage in provision of comprehensive post-abortal care. However, as you have seen today in the presentation, data from the DHIS2 shows that sharp curettage is still very much used in Tanzania, accounting for up to 16% of the post-abortal care services provided in the country. And our experience also shows that, you know, the higher the cadre, the more the tendency of providing sharp curated services. And I would say, you know, we kind of see a lot of resistance, you know, among senior doctors, senior gynecologists, while you would expect them to be the ones, you know, who are guiding us on how to do CPAC. They are the ones who kind of resist and they stick to the old-fashioned or obsolete practices. As a president-elect of AGOTA, would you please, we would like to hear from you why senior specialists are sticking to the old, obsolete practices. Karibu, Dr. Kapona.
Thank you, Dr. Joseph, for the invitation.
Sorry, I forgot to tell you, you have 5 minutes. 5 minutes.
Am I ahead?
Five.
I would like to start with the quality of services in our country. From the ongoing presentation, I think you had a clear picture of what is going on. So I wouldn't put more weights on that. But perhaps to say, when you are talking of quality, you are referring to the availability of the services. I think here the Ministry of Health has done a good job. Quite a number of health facilities are available throughout the country, and perhaps some few areas, because of geographical locations, perhaps they may be missing some of the facilities, but the facilities are available. And you also talk of the accessibility. And now, accessibility may be some problems may exist in this area, because once a woman had an abortion, then you expect the services will be promptly offered in order to minimize or prevent complications. Some providers may hesitate, either because of the personal views or because the laws perhaps does not accept it, whatever. That has brought some problems in provision of post-abortion care. But there's also an area where it has to be provided in, without judging. Some providers may tend to judge because, as we still know that abortion, as Professor has pointed, the law does not accept abortion. And therefore, when a woman presents herself to the facility, some providers may start asking unnecessary questions. Where, when, how, for what reasons. They want to know all these before providing what they're supposed to do, which is unnecessary, actually. When a woman comes with a problem, you as a provider, you are supposed to give the service and not to ask questions. So that slightly undermines the quality of service. And finally, the area of standard of care. It is good that the Ministry of Health, in collaboration with the other stakeholders, they have done a very good job offering the guidelines on how to take care of these patients when they avail themselves in the facilities. But it's unfortunate, sometimes these standards are not followed. And as the first speaker said, we find some sharp curate is still used. And it's unfortunate when I came to learn that if the seniors obstetricians are among the people who are resistant to adopt the proper methods of taking care of these patients. But I have my views. Historically, post-abortion care was provided in the country even before the current guidelines were formed. When we went to training, we were trained to help these women by a sharp curate. Until I finished my postgraduate, that was the standard method. Now, when we came to practice, I happened to be one among the people who started post-abortion care and introduced the MVA. And when this was introduced, it's unfortunate that the mid-level specialists or the junior specialists, they are the ones who were taken aboard or the ones who were selected to undergo the training. And most of the senior obstetricians were left to learn on their own. And perhaps on the assumption that once somebody is highly learned, will easily absorb or learn the new procedures. So at the end, they didn't learn. That's number one. But the second point, when we went to training, I went almost all over the country training in emergency obstetric care, including post-abortion care. I think one of the mistakes which was done is to include these senior people in the same class with everyone, the nurses, the clinical officers, medical officers, assistant medical officer, and then they found themselves perhaps in a foreign environment. So if something can be learned by a nurse, then why should they take a problem now, make efforts to learn? So they were actually in the class, but they were not in there by heart. So they didn't learn.
Thank you.
They didn't learn. And at the end, they were not able to perform the procedures required.
Yeah. So, Dr. Kapona, we hear you, but we are more interested in what are you going to do? You know, what should we do to bring senior medical professionals on board?
Okay, let me finish the last point. The last point, which I think, these are my opinion, please. The last point is that if a procedure can be performed by junior staff, a nurse midwife, then I don't think this procedure should be superior to the curettage which is done in the theater and aseptic condition, and you see. So perhaps many senior people saw MVA as an inferior procedure, and therefore they wanted to continue with the more superior procedure. When you're offering, you should choose the one which you think is the best. Now, coming to your question, what should we do? I think we should accept that we have done mistakes. And then we should now welcome the seniors, take them aboard. We have to, I'm thinking perhaps we should design a training which will include the seniors, whether they have been trained or they were not trained, but put them in a class with the same level. Perhaps they will learn and teach themselves, teach each other.
Okay.
And I think after that, we might see a positive, an impact after that training. That is my thinking.
Thank you so much, Dr. Kapona. I believe stakeholders have had the opportunity to bring on board, our senior specialists when it comes to, MVA and use of more modern and updated, approaches. So now let us hear from the horse's mouth. I'm saying from the horse's mouth because Dada Rehema, yeye ndiye anayotoa huduma kule vijibweni. So sisi hapa tunaongea, tuko kwenye stage, lakini yeye yuko kwenye side room na MVA kits mkononi mwake. So kwa hiyo we want to hear from you, Dada Rehema. As we understand, Vijibweni Hospital is one of the mojawapo facilities which provide CPAC services in Dar es Salaam. Can you please share with us, on average, how many CPAC clients do you attend in a month at your facility? And please, can you tell us a little bit about the profile of the clients you serve? Hao watu ambao unawahudumia ni kama wangapi kwa mwezi, lakini ni watu wa aina gani? Ni wazee, ni vijana, ni warefu, ni wafupi? How do you see your clients, A little bit about the profile so that we can understand. Asante, karibu, Dada Rehema. We have 5 minutes.
Asante, Mr. Joseph. Nitatumia lugha ya Kiswahili, nitachanganya kwa ajili ya kuweza kuweka ufafanuzi zaidi lugha ya nyumbani. Kama mlivyomsikia Mr. Joseph, naitwa Rehema, kutoka Vijibweni hospitali, ni afisa muuguzi, ni manager pale, lakini ni provider. Vijibweni hospitali tunapata wateja kwa mwezi wa hiyo CPAC services kuanzia kwenye 25 ina range mpaka 30. Yaani kwa siku ukiangalia hapo kwa siku maximum ya mgonjwa mmoja. Na hao wateja wanakuja kwa age tofauti. Na range kuanzia 20 years up to 35. Yaani ukiona above 35 ni mmoja sana. Lakini katika hao wateja wengi wao ni sisi wakina mama ambao tupo kwenye ndoa. Wapo na mabinti lakini sio kwa percent kubwa. Na tunajuaje? Kwa sababu ukisema kwamba huyu yuko married au single, na guide na tool yetu haiwezi ku-identify kwamba huyu ni ikaonyesha kwamba huyu ni married au single. Ile tool ya mtu namba 17 inaangalia parity. Lakini tunajuaje kwamba huyu yuko married au single? Pale kwenye pre-counseling unatakiwa uchukue proper history. Kwa hiyo kwenye history checking pale ndio utajua kwamba huyu ni either ni binti au ni mama ambao yuko kwenye ndoa. Kwa tunapata wateja wa namna hiyo. Na hao wateja wanakuja unapochukua history ili ujue huyu kwamba huyu mama amekuja au binti amekuja na mimba, either ilikuwa induced au ni spontaneous. Ni wewe unapochukua history pale kwenye pre ndio utakuwa uchukue history uweze kujua ni jinsi gani utamhudumia mteja. Kwa hiyo unachukua kuangalia asilimia kubwa ni spontaneous. Kwa sababu kusema induced huwezi kujua kwamba huyu ni induced au vipi mpaka uchukue history. Lakini unapochukua history ndio utajua kwamba hii ni spontaneous au induced. Lakini asilimia kubwa ni spontaneous wanaokuja pale. Kwa sisi ni wajibu wetu kama watu wa huduma bila kujudge kwamba either ame-induce au imetoka yenyewe. Sisi ni wajibu wetu ni kutoa huduma kutokana na huduma inayohitajika, huduma standard, kutokana na ile shida ambayo amekuja nayo.
Yeah. So Dada Rehema, I know Vijibweni mlikuwa mnapata support kutoka kwa miradi mbalimbali, especially PATHFINDER ambao waliacha kuwa support mwaka 2019.
Yes.
But you are still getting about 30 patients or 30 clients per month.
Yeah.
What have you done to sustain these services as a facility?
Okay. Tulikuwa tunapata support kwa hili kutoka kwa mdau ambao ni PATHFINDER International. Tumeanza nao muda mrefu mpaka 2019 tulipo graduate wakatuacha, lakini sio kwamba wao wameondoka kwamba service ita stop kwa sababu mdau ame stop. Lakini kama hospitali ambayo iko chini ya serikali tuna mpango kazi sisi wa kituo ambao kila mwaka tunapanga. Kwa sababu huduma ipo na wananchi wameshajua kuna service ambayo inatolewa pale kwenye kituo, lazima tulitengea budget. Kwa from there mpaka to date ipo budget ambayo inatoka kwenye mpango kazi wa hospitali kwa ajili ya zile surprise vifaa pamoja na dawa. Kwa sababu mnapotaka kumfanyia service huyo mteja before lazima kuna dawa ambayo unampa kwa ajili ya maumivu 30 minutes before procedure lazima umpe hiyo dawa. Kwa hiyo lazima uweze kupanga mpango kazi. Kuna vifaa, kuna hizo MVA set, kuna hizi speculum whatever, vifaa vingi ambavyo vinatumika mule ndani. Kwa hiyo vinakuwa kwenye budget ya hospitali. Kwa kila budget inapopangwa kwa kila kota mara 4 vifaa vinavyokuwa vinakuwa ordered MSD vinanunuliwa kutoka MSD. Kama kuna MSD tumekosa tunapata missed items tunanunua kwa mshitiri kutokana na utaratibu wa manunuzi. Na hatujawahi kumiss, kwa hiyo huduma mpaka sasa hivi zinaendelea, taratibu zote zinaendelea. Hakuna ukosefu wa vifaa pale, vifaa vipo kila siku store. Utakuta MVA set zipo na MVA room maximum lazima kuwe kuna MVA set 2. Hazitaki kupungua 2 MVA set katika chumba cha CPAP. Kwa ziko pale na store backup ipo. Kwa service lazima iendelee na watu wa huduma waendelee kutoa huduma kama ambavyo mdau alikuwa na support hapo nyuma. Kwa service still inaendelea vizuri kutokana na taratibu zinavyotakiwa.
Asante sana Dada Rema. I think we have a lot to learn, from Vijibwini Hospital, where services are sustained after, ending of programs which were supported by a partner. So now I will turn to Dada Jean. Dada Jean, I know you are a project manager for the program, which has been working to support these interventions. So can you tell us what is unique about your interventions, which made these interventions result into all these achievements we are seeing today? This rapid scale-up, buy-in from the government, sustainability, as Dada Rehema said. Can you tell us what is so unique about your approaches?
Thank you very much, Dr. Joseph, our moderator, and thank you for the audience and participants. So, as a program manager, we're trying to develop interventions that make the government on a driver's seat, meaning that we have to work together on the concept note for them to understand this is really a problem to their coverage and it needs intervention. So if we implement projects, we inject a project without them accepting it is a problem, for them it will not, there will not be ownership. So what we are doing is to make them understand the concept. We do the situation analysis together, then we agree on what to intervene. So again, our intervention was really focusing on what is available within the government system. If it is training, we were using the national trainers that were certified by the Ministry of Health. But again, the project did not have a separate tool for documenting anything on if there is a donor interest. So we're using the system the government has made us put in place for reporting. But again, we're using the same providers. We did not want to use a provider from Facility X to come support Facility Y. We make sure that we build the capacity on providers on the same facilities they're working. But again, there are another unique activities that we're doing. We're using experts available in the respective districts. For example, we've been working with Agota, knowing that there are wide coverage in the country. At least every district has an obstetrician who will support facilities on maternal health interventions. So again, we're trying to coordinate the support from Agota to ensure that they support the district and facilities to oversee the activities on maternal health intervention, which includes overseeing the quality of services, but again, coordinating mentorship activities to make sure that we get providers who have enough skills to perform, say, MVA, or to support all the CPAC activities within the respective districts. So again, to sustain the project, we've been working with managers at regional and district level to ensure that they include this, they do conduct focused work planning for their CCHPs to ensure that whatever is within the maternal health package for the CCHP should be well planned for the next year of budget, and at least to make sure that they implement as in their work plan.
Thank you. Thank you, Dada Jean. That is quite comprehensive, and I think we have a lot to learn from your interventions. Professor Pembe, you have already spoken, but when I look at the numbers you are presenting, the numbers are huge. We are talking about 3,000 clients per month from just 20% of health facilities in Tanzania. We are talking about a region like Dar es Salaam delivering 700 CPAC services per month, and that is only in public health facilities, not even including the private health facilities in Dar es Salaam, which are actually more than 70% in this area. So I'm so curious, are these numbers reflecting the truth on the ground? Are they overstated? Are they understated? What is your opinion about these numbers?
Thank you very much, moderator, for that interesting question. Look into the number from DHS2. And my view, according to the data which I have, for example, Kyoga et al., they estimated that the referral hospitals in Tanzania, including the zonal referral hospitals, they manage approximately 1,200 cases in a year. At the regional hospitals, it's 11,700 per year. When you come to the district hospitals, the range is wide, from 200 to 600. The health centers is about 70, and the dispensaries is around 20 to 40. Now, when you compute these numbers, according to the total number of facilities, which is more than 70,000 in Tanzania, then the number is very much underestimated. It's very much underestimated. And of interest to me, looking again to the services being provided, and I looked at the data of 2015, the CMOC assessment in Tanzania. It showed that comprehensive post-abortion care is available in most of the facilities. The most difficult which is there, the supplies. And then, when they look to the mortality and the complications, most of the women, according to that report of 2015, they are dying in the health centers and not in the hostels as it used to be in the past. Now, I go back to my own experience of conducting operational research in one of the health centers in Dar es Salaam for the harm reduction model for abortion. We chose one health center. We did an operational research for 3 months. What we did, first of all, is to train all service providers, managers, the gatekeepers, being the askari at the gate or anybody running a business around there, so that we can capture the women who are looking for the abortion services. For the 3 months, we got 100 women needing abortion services. And we took them through the process of the harm reduction, whereby you have to counsel these women on the complications related to different methods of abortion, the importance of preventing being pregnant in the future, and then we left for the woman to make a decision. And we made a follow-up. You could see exactly that through that research and what we observed, because with the operational research also we are observing the facility I was performing. Some of the abortions or some of the post-abortion care services were not recorded in the book. We end up only with 100, which we know. Therefore, the number are really underestimated, maybe more than what you have been collecting through the DHS in those 1,100 facilities.
Wow. So I can see Dr. Mokwani wants to say something, but Dr. Mokwani, you are going to be given an opportunity to speak as a closing remarks. We would like to give opportunities, for our audience colleagues here to ask some questions, and people who are online also may ask some questions. And please, when you raise a question, make sure you identify the panelists who you would like to respond to that question. Karibuni. Yes, Dr. Sande.